Yumi, Dr. Ando, who's on the call today, I've known for several years now, but she is the physician I work with for my hormone replacement therapy, and I've learned a lot over the last few years. And because there's so many questions out there and so much, I feel like mixed information and misinformation, and a lot of people that are doing my BFR program, I know we've talked about hormone replacement therapy, and obviously I'm not an expert in it, so I thought I'd bring on an expert so that we could kind of talk a little bit more about the topic overall, what's really happening through menopause, why we need treatment options, how it helps us long term, and then also save time to answer questions because I know a lot of people on this topic have individual questions and want to to have a resource of someone you can ask a question live. I think is really valuable. So anyway, I will turn it over to Dr. Ando. She can tell you a little bit more about her background, but I know she's been a doctor in the area, both at PAMP and now in her own concierge practice for a long time, and has a great mix of kind of Western and Eastern philosophies that I think is really valuable as a combination. So I'll let her talk a little bit more of that. But Dr. Ando, thanks for being here today.
Thank you, Ashley, and please call me Yumi. So I'm so happy to be here. I really, as I was saying earlier, there's increasingly, there's more information in social media. There are more books now on menopause. But I started really working in hormones probably 5 or 6 years ago. And I felt at the time I was sort of this lone soldier. I think at the time there were only 3 physicians on the peninsula, actual MDs, who were prescribing hormones for women. And this is just such a travesty. And even now, I did my training. I'm an internist and trained at Stanford. And even among my Stanford colleagues, there's still a resistance to hormones, which I'll go over a little bit about why that should not be the case. And I think, in this time, what I want to do is really talk about, and I don't really know all your backgrounds of what you're interested in. So I want to make this super interactive. My presentation is about half an hour, and I'm going to do pathophysiology, kind of what happens in menopause, what are the hormones, why are you feeling the way you're feeling, and then what can you do about it? What are the resources you have, and what are the remedies, and maybe dispel some of the myths. And then I really want to open up to questions. So, and along the way, if you have questions, interrupt me, raise your hand or put something in the chat box, and we can try to make this as interactive as possible because it's hard to be talked at, and I'm going to throw a ton of information at you. And just by way of background, I am double board certified. As Ashley was saying, I'm board certified in internal medicine, and I actually just recertified in integrative medicine. We have to recertify every 8 years in integrative medicine. So I just passed the boards for that. So I'm really excited. So I have two board certifications under my hat. And I will say that much of my hormone training did not come from the conventional medicine world. It came from the integrative part of my training. And I had to actually be very aggressive in exploring different training options and going to different conferences. And I took an advanced hormone training module through actually a little bit maybe dubious organization called the A4M, which is the Anti-Aging Medicine Society. But we can talk more about that later if you wish. All right. So without further ado, I'm going to share my slides and tell me if you can see where I'm starting. Play from start. All right, so this is just my introduction. All right, I always start by saying one of the things I want to dispel is the myth or this concept of women aging, right? So this is a man who's old, but we would open the door and invite him in for dinner. We'd have coffee with him. He's elegant, he's distinguished, he's got the gray hair, he looks quite wise, right? Nobody would turn down a date with Sean Connery. But this is what happens when women age, right? This is how often women are portrayed. And what I often hear from some of my patients are that women, even worse than this possibly, is that women become invisible as they get older. So I really feel like, one of my missions is to make this not happen to women and to have us really value our aging and embrace it as, we're not crones. I was actually appalled. I went to an integrative medicine conference and we were divided into meditation groups, and there were wizards and there were crones. And the men all got to be wizards and the women had to be crones. And it really rankled me that this terminology was being used. So anyway, I'm just saying that by way of introduction, something to think about. All right. So what happens in menopause? And I have to close my thing here. One of the things I wanted to point out is that this is a normal hormone cycle, right? So what I want you to pay attention to is the purple line here is estrogen and progesterone is here. So in your normal cycle, you have this kind of nice interaction between estrogen and progesterone, but they never go to zero. This is the y-axis in terms of values. You never sort of lose your hormones. They're just kind of cycling and you're cruising along. And, if you have perimenopausal symptoms, or I mean, if you have PMS, there can be alterations in this hormone cascade, but for the most part, we're pretty steady. But look what happens when you go into menopause. Oops, sorry. I'm trying to use my cursor to illustrate and I'm advancing the slides. So in menopause, what happens is when you're cruising in through perimenopause here, I want you to notice the first thing that plummets is what? Progesterone. Progesterone drops precipitously around the time of menopause. You can be having periods all the way through this portion of your journey, right? So this is the perimenopausal phase. Progesterone drops precipitously, and this is where women will come to me and they'll be like, "Oh my gosh, I can't multitask. Oh my gosh, I parked my car and I could not remember where I parked it." Or you get extremely irritable and moody. And so what's really happening here, that is all from the loss of progesterone. As you progress through the menopausal journey, what happens to estrogen is like it's just going like crazy, right? You're having crazy fluctuations of estrogen. And this is primarily what causes the vasomotor symptoms that we all are fondly know as hot flashes, night sweats. That's all predominantly the fluctuations in estrogen that are happening here. This is also a period, apologize, that where you may actually have some very irregular bleeding. You may go from having super short cycles. Often people will have extremely long cycles, or they may have a cycle where they actually don't stop bleeding. They're bleeding for 2 to 4 weeks. And then gradually what happens is the cycles will shorten and then they'll eventually drop out. And then when you're in this sort of post-menopausal phase, I think this drawing is actually not accurate. What really happens, again, sorry for my cursor, what really happens here is the progesterone and estrogen are both really low. Your estrogen is actually almost undetectable if you do a blood test or a saliva test, and that's when your periods stop completely. Okay, so that's just a little bit about what's happening in this part of your life. The other thing I want to point out, I always find this slide very interesting, and the purpose of this slide is to show you that here, and if I can use a cursor, this is when you have your period and you go from, not having periods is when you have your first period around 10, 11, 12. This is how great your fluctuations in hormones are. But look what happens when we're in perimenopause to menopause, right? I'm sorry. Your hormones are just going completely wacky. There's never been a time in your life where your hormones are more irregular and crazy than they are when you're in perimenopause and menopause. So just keep that in mind. Be kind to yourself if you're going through this phase of life. This is really what your physiology is doing to you. All right, so what is perimenopause? I think this is something that is not recognized well and often underappreciated and also untreated. So technically it is defined as around menopause, often starts in your low 40s and can go anywhere up to 50s. One of the things to please keep in mind is that, again, this is where you lose your progesterone. And I think progesterone is probably one of my favorite hormones and really overlooked. This is a period in your life where if you're starting to have brain fog and forgetfulness, a little bit of supplemental progesterone can make a huge difference. And this is also a period when your estrogen levels are, again, if you remember that graph, your estrogen levels are going a little bit wonky and your periods are getting a little wonky. And again, symptoms may or may not include hot flashes, depending on where you are with your estrogen. But sleep problems are a very big issue when you lose progesterone, moodiness, and then this brain fog. Anybody have questions yet? Everybody good? All right, so menopause by contrast is defined as the absence of periods for 12 months. Okay, so if you stop your period, you are technically kind of still in that perimenopausal period. If it's 12 months between your last period and you haven't bled, then you're officially in menopause. And in the US, the average age of menopause is about 50. This year, almost half of American women are menopausal, which I find is an astounding statistic, and about 2 million women are in menopause every year in the United States. So let me see if I can make this a bit larger. So here's what happens. These are all the symptoms that you can have in menopause, and you may or may not be familiar with this, but I'll just go over them really quickly. Headaches can occur. Sometimes if people have menstrual migraines, sometimes they get worse. Fortunately, most of my patients, when they transition through menopause, the migraines get better. Weight gain is extremely common, and a lot of people will come to me saying, okay, I have like, what's going on? I have gained this like belly, I have this belly spare tire around my waist. And that's because when you lose estrogen, you start to accumulate fat in the more male pattern. So you tend to get more belly fat. When we have estrogen, we tend to get fat on our boobs and our hips. And so that kind of changes, and you have this change in body morphology that most people do not welcome. You can get breast pain, breast enlargement. Skin changes are very common with dryness, itching, flaking, thinning. All of these are very common. Frozen shoulder is actually a very commonly high prevalence of frozen shoulder in women in their 50s. I had frozen shoulder when I went through menopause and had no idea that there was a correlation, but this is where treatment can make a very big difference. And by treatment, I'll talk about hormone replacement therapy. So sore joints. Urinary incontinence, we lose our vaginal estrogen as well, which allows the vaginal tissues to become quite thin and more susceptible to both vaginal yeast infections and urinary tract infections, and incontinence. And then there's all of the sort of psychological issues of difficulty concentrating, more irritability, depressed mood, and all of that, and also loss of libido as estrogen and testosterone levels drop. And then again, vaginal dryness and painful intercourse. So any questions now? Is there anything else that we don't experience? One of the things I was going to say is palpitations are quite common. And myself, when I went through menopause, I ended up in urgent care with palpitations, and I had not made the connection. And all of a sudden, everything was normal. And all of a sudden, the physician turned to me and was like, are you in menopause? And actually, that turned out to be the cause of my symptoms. So just a little bit more clearly, here's what estrogen does, improves your skin, helps you protect you from heart disease. I'm really a stickler. Women who are going through the menopausal transition should have their cholesterol checked because you can have profound alterations in your lipids during this time. Again, bone density, breast health, vaginal health, these are all very important roles for estrogen. Progesterone, again, my best loved, overlooked hormone. Again, it's extremely calming. I don't know if all of you, if you've had kids in that third trimester, progesterone levels are incredibly high. And this is the time when you're sort of feeling really calm and you want to nest and you want to roost. And so progesterone does all these things of just like very calming, helps you sleep at night. Also really important for bone density, and also attenuates some of the effects of estrogen on the breasts. And it's actually very helpful for immune system. So there are a lot of conventional physicians who will replace hormones in women. And if a woman has a hysterectomy, they will not use progesterone. And I can go into this a little bit nuanced, but I actually firmly believe that even if you don't have a uterus, you should take progesterone with estrogen because it's all a hormone symphony, and progesterone is extremely important for health. And finally, testosterone, again, an overlooked hormone, but very important. We actually make more testosterone than estrogen. And I think there's sort of a myth that, testosterone is a male hormone. Actually, both genders have testosterone and estrogen, and they're just in different amounts. So testosterone, extremely important for brain health and spatial memory, helps with your blood cell secretion, muscle development, as all of you know who are doing BFR, as well as bone density and skin. So, all right, I'm going to talk about the seven dwarves of menopause: itchy, bitchy, sweaty, sleepy, bloated, forgetful, and psycho. Right? Anyone ring a bell for people? Why are you feeling this way? So when you're sweaty and sleepy, this has to do with drop in estrogen, as I talked about before. It's that cycle where your estrogen's going really wonky and you can no longer sort of vasoregulate or regulate your temperature. So you have hot flashes, or you're doing a presentation, you start to sweat. men in boardrooms never have this problem, but I have a lot of female, women CEOs, and they're giving presentations and they're just sweating like crazy. So this is what's happening. And then the disrupted sleep is often because you're getting hot flashes at night, and also because you're losing the kind of anti-anxiety effects of progesterone. All righty, bitchy and psycho. Again, loss of estrogen and progesterone, right? The data has shown that women have almost a 2 to 3-fold risk of depression during menopause. A lot of this has to do with the ratio of estrogen and progesterone that occurs, but also the drop in both hormones. And then the bloating, again, we talked about this before, the distribution to weight in a more male pattern, just around the belly, just where you don't want it. There's about a 10% increase in abdominal fat that can occur. Average weight gain can be about 5 pounds. I will say that being on menopausal hormone therapy can mitigate a lot of this. And then the itchiness comes again from the loss of testosterone as well as estrogen that can cause skin changes. You may notice your hair getting drier or some hair loss. There's more vaginal atrophy, more skin wrinkling. You can get some female pattern hair loss, and dry eyes are actually also associated with menopause and increased risk of heart cataracts during this phase of your life. Lots of fun stuff. And then droopy and toothy, again, they're related to the loss of estrogen and testosterone. So one of the really big things to point out is your bone mineral density declines. You lose the most amount of bone the first 2 years after menopause. And then thereafter, you lose bone. If you don't do anything to counteract it, your bone loss is about 1% per year, which is why doing things like weight-bearing exercise and BFR are so important at this time. And I really encourage all my menopausal patients to do some kind of resistance training. I send everybody to Ashley to do BFR. I think this is a really key intervention here. So other things to think about, oral health can be dramatically affected by loss of estrogen and testosterone as well. All right, and sexuality, sometimes not often talked about in your doctor's office, but women are quite a bit more likely to lose libido as they get older and as their hormones are changing. This is an old survey from 2007, but about a quarter of women over the age of 57 did not enjoy sex. Sex can become quite painful because of the loss of the vaginal integrity. And you also have reduced blood flow to the vagina, the vaginal walls, and lowered sensitivity. So, and then finally, cognition, I think, is not to be underestimated. This is, again, both losing estrogen, progesterone. We know women have a twofold increased risk of Alzheimer's. We have a ton of estrogen receptors in our brain that is sucking up estrogen. And so all of a sudden this deposit of estrogen dries up and the brain becomes essentially hypometabolic. So we're looking more and more data coming out showing that hormone replacement therapy around menopause can significantly reduce the risk of Alzheimer's disease. And if I have a woman who has a strong family history, this is actually one of my suggestions for her. All right, this is super fast, kind of overview of hormones, pathophysiology. This is the game of menopause. And so what can you do? Before I go on to some of the steps, are there any questions? Because I'm going to transition into kind of intervention and treatments. Everybody good? Okay. So what can you do? First of all, lifestyle cannot be overemphasized. I put in here another plug for BFR. I do BFR. I really think this is a game changer for all of my menopausal women. It's short, it's fast, it improves your IGF, improves your growth hormone. It's the only thing I know that can effectively and efficiently help with resistance training. And then obviously diet is really important. Emphasis on low carb, low sugar, and unfortunately low alcohol. Stress reduction, incredibly important as hormones are going crazy. Hormones and cortisol are very closely related. What happens if you're stressed is your body actually makes cortisol instead of making hormones. So if you're in the process of losing hormones through menopause and you're stressed, you can exacerbate some of that loss. So meditation and making sure you're sleeping well are really important interventions. And then finally, menopausal hormone therapy is now called MHT. So go over that. So here is an area of great confusion, which I'm hoping to help clarify. What are bioidentical hormones? I know this is bandied about a lot. Sometimes people are not clear on what it is, and I actually think it's a little bit confusing. So what I have here on the top are bioidentical hormones. This simply means that these are hormones that are identical in structure to the hormones that your body makes. Okay. So we all have three different forms of estrogen in our bodies. It's very simple to remember. E1 is estrone. There's a one in it. E2 is estradiol. This is the most abundant form and quite potent. And E3 is estriol. It's got the trio in it, right? So those are the three hormones that your body makes. And these are bioidentical, and the compounds that are available on the market that are bioidentical will have chemical structures that are exactly that you would map them one-to-one onto these hormones. But I think it's a misnomer because bioidentical implies natural, but they're also synthetic in that they're made in a factory in a lab, but they're bioidentical, if that distinction is clear. By contrast, the hormones you see on the bottom, these three hormones are synthetic. And if you look at their chemical structures, they're not similar to this 17 alpha ethinyl estradiol maps to the estradiol sort of kitty corner above it, but it's chemically not identical. So it's a synthetic hormone. This is the most common hormone used in birth control pills. So that's the distinction between bioidentical and synthetic. So I hope that I made that clear. So what do you use? So obviously my preference is always to use bioidentical hormones. We have really good data about safety. A lot of the studies that the one study that threw hormones under the bus was the Women's Health Initiative, which actually there was one study arm that used synthetic progesterone, and the women in that study arm had a much higher risk of breast cancer, heart disease, and strokes. And because of that one arm in the study, all hormones got a bad rap. And so we went from 40% of women being prescribed with hormones right before 2002 when the study came out to after the study, now only 10% of American women are on hormone replacement therapy. The study did that much damage to hormones. And really what it is that the synthetic progesterone is the single bad actor. So if you actually remove synthetic progesterone from the equation and you're using bioidentical micronized progesterone and bioidentical estradiol, there is no increased risk of breast cancer and there's no increased risk of heart disease or stroke. So it's been very abundantly clear now that these are incredibly safe. They're FDA approved and you can buy them at any local pharmacy. You can go to your Walmart, your Walgreens, or your CVS. The caveat is that compounded bioidentical hormones, which do exist, and I do use them, and I can explain why, that is not FDA approved because FDAs cannot approve all the compounding pharmacies in the universe. But if you work with a compounding pharmacy that's very reliable, that you trust, you can still get these medications quite safely. Compounding allows you to be a little bit more finessing with your dosing, as well as your mode of application. All right. And so ultimately, I think whether to use or not to use hormones is a personal preference, can depend on your symptoms. I personally think it's a huge improvement in quality of life and really good for brain, heart, bone, and skin. But bottom line is it's always going to be a personal preference. I want everyone to have the knowledge and make an informed decision as to what's best for themselves. All right, so here are examples of FDA-approved bioidentical estrogen, which comes in the form of estradiol. These are what you can buy at any local pharmacy. And I have an example, I don't know if you can see, this is the estradiol patch. So the patch comes in all the different brand names there, Alora, Vivelle, Dottie, and Climera. All the ones, the three on the top are a patch that you put on twice a week. So typically my patients will put one on a Sunday and then change it on a Wednesday, like Wednesday morning, Sunday night type of thing. Climera is a patch that is a once a week patch. It's some people like it. I don't tend to like it. This is a really nice, small, non-intrusive. You can swim with it. You almost don't feel it. You put it in your bikini area. The Climera patch is sort of made of cloth and it's bigger. It's this big. I find it a little bit more intrusive than this, but a lot of my patients do like it because it's once a week and it's a lot easier to remember than twice a week. There are also gels. If people like gels, very few people sometimes develop a little bit of irritation to the patch. I've had almost no one in that category, but if that happens, you can use a gel. These are all also FDA approved, and those are their brand names: Divigel, Elestrin, and Estrogel. You put that on once a day, usually inner arm, in this area, or upper thigh. The only issue with the gels is there is a slight issue with transference. So you can transfer to a partner or a child, and so you have to make sure it's rubbed in really well. Final option that's FDA approved is something called FemRing, which is this vaginal ring, looks like a donut. You insert it vaginally, and it's a slow release of systemic estrogen, and you only have to change it every 3 months. Biggest issue with this is getting insurance to approve it. So those are the options here. So vaginal hormones, I'm going to go out on a soapbox and say that everyone in menopause should be on vaginal estradiol. Why? Because you need to take care of your vagina the way you take care of your face, right? It needs to be moisturized. It significantly reduces the risk of UTIs, vaginal infections, makes sex better, the whole kit and caboodle. So here are some of the products you can find, again, that are FDA approved for vaginal use. And one thing I would say is that very important to note, the application of vaginal hormones does not increase systemic hormone levels. So extremely safe in breast cancer survivors and cancer survivors. There's absolutely no risk and no reason that you couldn't be on one of these agents with a history of cancer. So you have the E-string, which is a vaginal ring. Again, you can change it every 3 months. It's not messy. It's very nice. And then there are vaginal tablets, and these are the examples of the vaginal tablet. You just stick it in and it dissolves. And then I think the creams are really nice because you can apply them both externally and internally to get a little bit of external use. And a nice tip here, you can actually take a little bit of your vaginal estradiol and put it around your eyes. It's a great skin product. One final plug here is there's something called vaginal DHEA. DHEA is a precursor to testosterone. So we have a lot of DHEA receptors in our vaginal tissues as well. And if you supplement them with DHEA, you can also increase the compliance and kind of lubrication of the vaginal area. So this is a really nice product as well for people who have severe vaginal dryness and painful sex. Another issue with this, again, many of these are getting insurance approval. I've had many tries to get this approved, and it's quite expensive if it's not approved, unfortunately, but it is an option. All right, progesterone. Again, this is my favorite hormone. I think it's overlooked. It is micronized to be absorbed orally, and it's FDA approved, so you can buy it at your Walmart. Most of my women find it extremely calming. I have people take it at bedtime before they go to sleep, and it really helps people sleep well. There are a very few people in the universe who, when they start taking oral progesterone, get extremely moody with it. It's a very small subset. So in those patients, I switch them to a topical form. Unfortunately, topical progesterone is not available as an FDA-approved product, so that has to be done in a compounded pharmacy. Just a little addition here, many of my patients are on a Mirena IUD. Something to note is the Mirena IUD contains a synthetic progesterone, so it's not my favorite form of progesterone. But the caveat here again is that the progesterone dose used in the Mirena is extremely low. So I do think it is fairly low risk, but just something to be aware of. I see something in my chat. Okay, I thought it was a question. All right.
Yeah,
And then
there was the question, curious of the dosage of progesterone you recommend.
Dose of progesterone, again, this is something that gets into a little bit of the fine weeds, but it's typically between 100 milligrams at night or 200 milligrams. I always start low and go slow, so I always start at 100 milligrams and then go up from there. If you're using progesterone also in the perimenopausal period, usually 100 milligrams at night, just in the latter half of your cycle, can be extremely beneficial. Really helps with that brain fog. Oops. Sorry. And all right, so testosterone. What are the FDA-approved testosterone for women? Zero. There are no FDA-approved testosterone products for women. I put over here on the right, oops, sorry, I'm having cursor fun. What are the FDA-approved products for men? This is only one page of the available products on the market for men. I couldn't even put 2 pages in. So this is an area of great inequality. I know there's a big movement in some of the urology and sexual medicine fields to have testosterone approved. Testosterone is now a controlled substance. You need a triplicate. It's a pain in the butt to prescribe it. So this is an area of, I think, gross oversight because women also need testosterone. So what do we do? I end up sending it to a compounded pharmacy. And here's an example of how it will come to you. It's called a topic click. It looks like a deodorant thing. You click one click, and it delivers a small amount of, this one's empty because it's a sample, but it delivers a small amount of hormone here. You simply apply it to your upper thigh until, again, it really gets well absorbed, and that's your topical testosterone. There are women, and there's a lot on social media now where women are using androgel, the male, which is the male form of androgel, putting it in a little syringe and taking 1/10 of the dose of the androgel and applying that topically. And that's another way that you can get it. It's a little harder. I think that's a little harder because when it's compounded this way and you click it, you know exactly how much you're getting. When you're finessing around with the androgel and you're doing it yourself, dosing could be a little less accurate, but it's still widely used in that context. So libido, just a little comment here. Again, testosterone is really important, I think, for libido, and then the vaginal estradiol or estriol, again, to help with the vaginal lubrication. Coconut oil, something I recommend. And then there are 2 new products on the market. I don't know if you guys have heard of this, and I'll just throw them out there, Addy and Vyleesi. Addy is a medication. It's a pill you take every night. It's like the female Viagra, but you have to take it every night. You cannot take it when you drink alcohol. I think you can have up to 1 or 2 glasses. Anything over 3 glasses, you cannot take Addy that night. It is also not FDA approved for menopausal women. Was only tested in younger women, but I just went to a sexual medicine conference and everybody is using it off label for women in menopause and saying it has fabulous results. Vyleesi is an injection, and you actually inject it. It's kind of like Viagra. You inject it 45 minutes before sex, and I think it lasts for up to 24 hours. And it doesn't have the alcohol interaction. And so a lot of women are liking that too. And they're doing a lot of branding. It comes in a nice pink, pen anyway. So just some things to keep in mind if these are non-hormonal approaches to increasing libido. And then obviously lifestyle. And I can't, again, emphasize enough the BFR training that can help with all of this too. And yoga is also really good. All right, so what's the best form of hormone therapy? I'm going to show you a couple things here just in my toolbox, just show and tell for fun. So again, this is a patch. Estrogen should always be topical. I love the patch. If some of my patients don't really like the patch, we can also compound this little vaginal pellet. I don't know if you can see this. Can you guys see this? This is like a little tiny little white thing, almost looks like a chiclet. This is a compounded estrogen and can actually be combined with progesterone. You stick it in your vagina every day, and that can deliver your hormones systemically. And then you can get a gel or a cream. Here's a nice view of what a cream might look like. This would be compounded. You can get gels or creams that are FDA approved from a local pharmacy. And then progesterone, again, it's the oral pill. And then if you want it topically or a vaginal insert, those have to be compounded. And testosterone, we talked about, has to be compounded and it's topical application. So I think I'm going to stop now. That's a lot of information. I'll just briefly kind of run over this. Should you test your hormones and how should you test your hormones? This is an area of extremely great controversy. If you go to a conventional physician and you go to My Alloy Health or MIDI, they're going to give you hormones and they will not be testing your levels. There's nothing per se that's wrong with that. Going by symptoms should be totally fine. And most women do very nicely within a nice, standard dosing. There's been no problems. Personally, I prefer to test because I find that there are little nuances in ratios of estrogen and progesterone that's really nice to know and often will correlate with symptoms my patients are having. So if someone comes in to me and saying they're having vaginal bleeding, I know it's almost always because their estrogen is too high relative to progesterone. Sometimes it's nice to have a test to show that, as opposed to just treating. I have had cases where women have come to me on hormones feeling fine, and I test them and they're actually super therapeutic. So there's no reason to necessarily be super therapeutic if we can get you into a nice target. So those are some of the reasons that I prefer testing. But again, it's not absolutely essential. And the form of testing that I prefer is through saliva. And it's a little bit of a pain if anyone has done it. You have to spit into a tube and collect quite a big sample of saliva, but it provides a much more accurate view of your tissue levels of hormones than a blood test will, for a lot of scientific reasons of hormone binding, all that. So that's my personal preference, but it's by all means not necessarily absolutely essential that you test. Finally, I think the last thing I just wanted to give you guys some amazing resources if you want to read more about this. I love Kelly Kasperson. I actually had the luck to sit and have dinner with her at a sexual medicine conference. She's extremely dynamic. Her podcast is great. She's very exuberant, energetic. She's a huge testosterone fan. If you don't know her, it'd be great to check her out. She has a really good podcast on dermatology. The new Menopause book that just came out, again, Mary Claire Haver has been a big voice in the menopause arena. I have to admit, I have not read it, just came out. It's on my book, it's on my nightstand to read. And then Estrogen Matters has been around for a long time. This is a book that I give all my patients. This was written by actually an oncologist and a sociologist to really dispel all the myths that the Women's Health Initiative caused about hormones and the risk of hormones. And it's very clear on the no correlation of breast cancer and hormones. And I think Avram Blooming's wife is also a breast cancer survivor and takes hormone replacement therapy. So it's a very good book if you want to check out some resources. So that's it. I threw a ton of information at you. I went over my time, my sort of 30 minutes that I was hoping to do this in, but I'm happy to answer questions. I think that's where
So
the money is. So
a few came in through the chat, Yumi. Can you
sure.
see the chat?
Let
Do you
me
want me
open
to read them to you?
let's see. Curious dose of progesterone. So we got that. Could you please explain your recommendations for application of coconut oil? Oh, yeah. I mean, you just actually, I heard this from one of my OBGYN colleagues that I don't know if this is still the case. Trader Joe's used to sell these little individual packets of coconut oil, like a little lube. And basically, you actually just apply it mostly in the external area, and it just is a really nice vaginal lubricant, odorless, non-toxic. So really great to have them. She used to tell people to have a ton of them in their bags when they were, going places. So cortisol, oh yeah, so really good question. So how can you talk about how cortisol affects estrogen? So cortisol if you think about all your sex hormones, and there's this lovely diagram, but cortisol, estrogen, testosterone, they're all come from the same precursor molecule, and then they get metabolized in your body. So when your adrenal gland makes cortisol, what happens is if you're really stressed, you're needing to make your body automatically makes more cortisol. And it's something called what we call cortisol steal, where your body is preferentially going down the route of making cortisol at the expense of making hormones. So it's this one supply that has to go to all of these hormones, including cortisol. But if cortisol is needed by the body because you're stressed, you're going to shunt everything to cortisol and you're going to then deplete your levels of all sex hormones. So that's the correlation there. So oftentimes if I have women who come in and I put them on hormone replacement therapy and they're not feeling better, this is when I test them and I see that their cortisol levels are super high. They're not going to feel better unless we work on getting their cortisol down. There's no amount of hormones that will make someone better if their cortisol is sky high. So that's where sleep, meditation, mindfulness, deep breathing, yoga, all super important here. This is not just throwing hormones at you. It's just all being holistic. You got to eat well. You got to move your body. You got to relax. And we're all caregivers and we all take care of other people. So this is really, I always tell my women, this is the time you need to take care of yourself. You really need to, your hormones are going batshit crazy more than they ever have in your entire life. This is a time for self-care and listening to your body. Spotting could be a sign. Let's see, sorry. Spotting could be a sign that estradiol and progesterone. Yes, spotting almost always means you're what we call estrogen dominant. Your estrogen level is too high relative to progesterone. So if I have a woman on hormones, it's very common to get a little spotting right after you start as you're adjusting. If you're bleeding a lot, then you need to increase your progesterone or lower the estrogen or do both. And that can be extremely helpful. Where can we do a saliva test? I don't know if there are companies that will do direct to consumer testing. There's a company called Rupa Labs. You might check out. It's Rupa Labs if you Google it. I order all my tests through Rupa Labs. You might be able to go online as a patient and order your own. I'm not entirely sure, but that's where I order my tests. I order through a company called ZRT. They are the sort of gold standard, at least in the integrated medicine world. ZRT has been doing this for a long time. They're highly trusted and very accurate. So that's how I do my saliva test. Saliva started ENP at 57 treat osteoporosis, menopause at 50, so safe. Yes. Very, very safe. So here's another area, another question. There is data suggesting that the sooner you start hormones around menopause, the safer and better it is. So within 5 years of menopause, there is some data saying if you start it after that period, you do have an increased risk of heart disease and strokes in that first year after starting it. I always counsel my patients on obviously it's a case-to-case basis. It's still lower doses than what we had in birth control pills, still lower doses than you had when you were pregnant. So if you have no risk factors and you're super healthy, I have no problem starting women in their 60s. I just started a woman at 65 for cognitive reasons. You just counsel and make sure you understand risk benefit. I personally feel the benefits outweigh the risks. I think if there was someone who was extremely high risk for heart disease, and we were thinking about starting in her 60s, that might give me pause. But again, it's a very case-by-case basis. So I have no problem starting later. There's also just a segue on that. There's a lot of teaching in conventional medicine that, oh, you only should be on hormones for 5 years and then stop because longer term use is not, we don't know. I think you can be on hormones indefinitely. I intend to take mine, forever. There's no reason that you cannot be on them safely for the duration. And I do know, just anecdotally, have patients who in their 80s are still on hormones and somehow some other doctor takes them off and then everyone is like, oh my gosh, they aged overnight. So really important for brain health. So I can't stress that enough. So dose for bone health is just standard hormone replacement therapy dose. There's not really a defined dose. It's whatever dose we have that usually gets you to a nice target estrogen level. And then very important to sort of monitor your bone density. One of the crazy things about American medicine is we're very we're very reactive. We're not proactive. So the U.S. Preventive Task Force does not cover or recommend bone density until 65. That's crazy. I get bone densities on all my patients around 50 because I want to know this is right when you're going into menopause. You're going to lose the most bone mass in that first 2 years. I want to get your baseline essentially and then follow you every 2 years to see that we're preventing further bone loss. So that's sort of my pet peeve. Do you test cortisol via saliva? Yes, you always want to test cortisol with saliva. Cortisol with blood testing is not very accurate, and all of the reputable saliva hormone tests will always have cortisol because it's so important and part of this whole hormone symphony. How do we test cortisol blood test? Again, not reliable in a blood test. Usually, cortisol can fluctuate so dramatically. Blood levels are not an accurate depiction of total body stores. It's really a saliva test you need. To be a really accurate cortisol test too, you need to do what we call a 4-point test. So it's first morning saliva sample, noon saliva sample, dinner time saliva sample, and then bedtime saliva sample. And that gives you, you're supposed to have a very nice curve where your cortisol is higher in the morning and then it goes, lower towards the evening so that you can go to sleep. And if that curve is sort of abnormal, then we need to really work on things. I'm already on birth control due to endometriosis. She'll take me up around 55. I'm 53. Should I stay on that or would you recommend MHT? What's the difference between these two hormones? Sorry if I missed this. So this is what I like to do, and it by no means, the be all and end all. I like to transition my patients from birth control pills to hormone replacement therapy because I do think they're safer because they're bioidentical and they're not synthetic. And I think the dosing is lower. And you're not really needing it for birth control. We're really looking at it as preventive for bone, brain, skin, hot flashes, and all that. So I will actually often just transition someone from their OCPs to MHT. And that can be kind of nuanced, but I have no problem doing that. And it can also help with endometriosis as well if you get the dosing correct. I hope that answers the question. What to do if your male doctor's not a fan of HRT? How do I get HRT? Oh my gosh. And this is not just men. There are many women doctors who also be like, you only take HRT for symptoms. You should take it for at least amount of time as possible. Or if you have any family history of breast cancer, they're just like, oh my gosh, I'm not going to prescribe it for you. Or why are you doing crazy things? I'm hoping to dispel this. There are more and more and more physicians in the community who are now open to hormone replacement therapy. There's a woman named Sally Greenwald who has a private GYN practice who does hormones specifically. I don't know what her price is. I don't know if she's inexpensive. There's a woman at PAMF named Jessica Cassis, Kassis, who's very open to hormone replacement therapy. She's a GYN. She is amazing, and I work with her quite a bit. If you want to go sort of telemedicine route, My Alloy Health is a wonderful Kelly Kasperson, who I mentioned in the podcast, is one of the doctors on My Alloy. They will do telemedicine and prescribe hormones for you. There's also MIDI Health, MIDI, also telemedicine that will prescribe hormones for you where you can get them. Or other resources. I wish there were more. I mean, but 6 years ago when I started doing this, there was no one. Now at least there's Jessica Cassis and Sally Greenwald. So I'm happy to have some companions here. I think there'll be more and more, I'm hoping. What do you think of the Dutch test? I think the Dutch test is fine. I think it's really good. It's a matter of preference. For me, it's pattern recognition. So a lot of naturopaths love the Dutch test. I think it's a little complicated and hard to interpret, but it's very good quality. So Dutch is fine. I just happen to love ZRT and I'm used to ordering ZRT. So that's what I do. If you have a gut that doesn't absorb vitamins and minerals enough, how can I be sure I'm getting enough progesterone to protect uterus? Yeah, you do need a saliva test. So if you're taking oral progesterone and you're not a good absorber, there is a chance that your levels may not be high enough. Progesterone to begin with in normal people is not very well absorbed orally. So it really passes through quite quickly. You might be a person who might be better off with a little bit of topical progesterone. And oftentimes I'll combine an oral progesterone because it gives you the nice soporific, anti-anxiety effects. But if someone needs a little bump, I'll add a little bit of topical progesterone on top of that. The topical progesterone does not give you the nice anti-anxiety calming benefits, but it's really well absorbed. And so, but to really know that, you'll need to have a saliva test to see exactly where you are. And then that's where testing can be really helpful because then you can titrate your dose and know that you're getting what you're being given. Can we order ZRT saliva testing ourselves? I don't, it's a good question. I would go to Rupa and see if they have a direct to consumer capability. I don't know, to be honest. As a physician, I can order tests through Rupa. I don't know if you can go direct to consumer, but I can try to find out and I can let Ashley know. It would be nice because there are more and more companies that are letting women take, medicine into their own hands. This would be a nice thing to add. So the company is Rupa, I'll write it here, Rupa Labs. And they're great. They actually have a number of different integrative medicine tests that they're kind of a Walmart of testing. So they're great.
Louise Cochran has her hand raised. Louise, did you have a question? You want to just unmute yourself and ask? Are you still? I know that was from a while ago.
Yes. Yes. Hold on. Let's get rid of that hand now. Okay. One thing was public service announcement, and that is based on my experience. I was suffering from anxiety and burnout, ended up in the long exploration of things that it was actually perimenopause, but I was able to claim state disability. So my doctor was able to help me get some compensation and let me reduce the amount of hours I had to be at work. So I just wanted to put it out there as a really great support mechanism financially, so you don't have to work your patootie off just and work through it, because that actually exacerbates it more. But my question is there such things as a primary care doctor that takes Anthem Blue Cross insurance that has the integrative medicine behind them as well? Because I'm paying for all my hormone replacement therapy and all my integrative medicine out of pocket. And maybe I'll get out of a network a reimbursement of up to 70% if I'm lucky. But most of the time, no. And I'm just like, well, that's the price I pay for my sanity.
I mean, I could go to a whole diatribe on American medicine and our system being broken and why I'm doing concierge medicine and not practicing at PAMF where I was for 15 years. It's very sad. I don't know so number one, you can't find a primary care physician who maybe has the time or the energy or the bandwidth necessarily to talk about hormones at this length or even understand the bioidentical hormone field. However, PAMF does have, and you may be aware of this or not, PAMF does have an integrative medicine group. I was part of that when I was there. I left in 2015. But the group is still alive and active. They are not your primary care physicians, though. They are integrative medicine specialists, so they're consults. So what you could do is go to someplace like PAMP for your primary care, and then go to the integrative medicine, which is, I believe, insurance covered, and get hormones through the integrative medicine clinic. You wouldn't have the integrative aspect, but at least you might get some covered services that way. Just an idea.
If someone, I think several people on this call aren't local, Yumi, so would
Um,
they just kind of look for an integrative practice within their,
Yeah, I
um,
mean, I think the nice thing about the telemedicine companies is if you want to go that route is that they don't have state borders. They have licenses in most states. So MIDI and Alloy Health are really great resources that way. And they're both companies I think are women founded. So I'd love to support them. They don't do testing, but they will give you good hormones. If you want to really go deep and do the testing, then you may have to find an integrative practitioner. I think you can go if you go to the Menopause Society website, you can find practitioners there is menopausal training from the Menopause Society. You can find practitioners that have gone through that training on their website by state, and that might be another resource to check. You can also
Yumi?
yeah, I was going to say you can also go to A4M. I'll type it here in the chat. A4M I did my hormone training through A4M. And they also have a list of practitioners that have done that training, and that's nationwide too. So there is one guy at PAMF. He's a little odd. He's a little wacky, but he does hormones. His name is Andrew Juro. He's at PAMF. I don't want to sort of speak ill of my colleagues. He's a little wacky. He has A4M training and is at PAMF and does bioidentical hormones, and that would be covered by insurance. But I think he's a GYN. It wouldn't be primary care. So unfortunately, yeah. Anyway, I won't say anymore. A lot of thoughts, but I'd love feedback. I hope this was clear. I feel like I threw a ton of information at you. I don't know where anyone's coming from, what baseline knowledge people have. I hope the distinction between bioidentical, synthetic was clear. I hope you understand kind of the different ways of applying hormones. I don't know if I went over that too quickly. Please let me know if you have more questions, and Ashley knows how to reach me. I hope it was helpful.
You're getting good feedback, Dr. Yumi.
Oh,
Everyone's saying
good.
very helpful, amazing.
Oh, awesome. Awesome.
People want us to live a test now. A couple people are asking if you take patients and where you're located.
Yeah.
Yeah.
So, I mean, this is where, I mean, I'm passionate about this. I love to talk about this. I could talk about this for a long time. I'm in Menlo Park. I have a private practice. I was, and as Ashley knows, I have a hormone program that's separate from my concierge program, but unfortunately, I can't do it anymore. I don't have the bandwidth to be able to take the number of patients on and walk them through this journey the way I want to if I'm doing the testing that I'm doing. So if anyone has a business mind and wants to help figure out how to scale this, I am more than happy to figure out how we can scale this because I think that this is incredibly important for women and women need to have access to it. And there's not enough in our community. I think if you go to Berkeley, Marin, there's a lot more, but somehow in our refined area of the peninsula that's overshadowed by Stanford, I feel that there's a dearth of practitioners in this field. So I'm open to figuring out how to expand this and disseminate knowledge and get women access to hormones that's so helpful. I just don't know how to do it on my own. And I'm not a business person, so I would be happy to join forces. Yeah, I really appreciate the comment on A4M. I'm always a little bit sheepish when I say that I did my training through A4M. I think their hormone training is excellent. I don't know if any one of you knows about A4M. The thing I don't like about A4M is their overemphasis on appearance and plastic surgery and kind of these like not embracing aging, but really trying to look different. I mean, it's just not an approach that I really want to endorse. So although I think their hormone training was excellent, the other parts of that whole organization, I'm not a big fan of. I'm a very big fan of the ISWITCH, which is the International Society for Research in Women's Sexual Health. That's a great group of urologists and gynecologists that I've just become part of and really are trying to champion women's sexuality and women's hormones. So if that helps, they're a great organization. So happy to do part 2 if anyone is interested. I don't know what I would talk about, but more if there's more Q&A, I'm open to it. So if someone asks what organization is that? Oh, ISWITCH. I think it's like international, something like that. If you Google that and say sexual medicine, you'll find it. I don't remember exactly. It's a long acronym, but it is an international sexual medicine organization for physicians, but they may have some patient-facing things too. So,
Thank you. All right, so we will wrap it up there. That was amazing, Yumi. Thank you so much. And for all of you that stayed on this whole time and asked great questions, I can tell it's a very, topic that people want to learn about. And as Yumi said, too bad there's not more information out there, but I do think we're moving in the right direction and hopefully that will move quickly as there's a lot of people, looking for this information. If you have more questions, I think you all have my email. I'm going to send out this recording to everyone, but if you have questions, feel free to email me. I can always get some more answers from Yumi and share them with the group through email. And then if there is enough interest, we can talk about doing something, a follow-up to this at some point. But anyway, thanks all for being here. Thanks again, Yumi. Yes, great job. Great information.
guys, thank you. I'm hoping it's helpful. All right. Have a good day.
All right. See you all. Thank you.